Hi, I'm Stephanie Shelton, and this is Conversations on Health, How We Get There. It's episode 17. So I'm starting the 2024 season by celebrating the podcast's first year and a half, 16 episodes. That is wow. We had a widely varied group of subjects and widely varied guests. Some are experts on healthcare systems. Others are just people trying to navigate their way through the privately driven U.S. system to see if it works, or for many of them, to see that it doesn't work. Maybe you'll find one or two of the conversations that you missed. I'm going to start right at the beginning, in the Czech Republic, with Dr. David Marks. He is the internationally recognized expert who heads the Department of Public Health of the Third Faculty of Medicine at the renowned Charles University Medical Program. And he also heads the Hospital Accreditation Program for the Czech Republic. Now, during the podcast interview in his office in Prague, we talked about the Czech government-run healthcare system. Like others in Europe, Czechs pay relatively high taxes, but then they never worry, as Americans do, about getting sick and worrying about how they're going to pay for it. However, medical costs are rising everywhere, including the Czech Republic, and Dr. Marks said the system will need tweaking to survive.
I think the only path for the future is rationing of healthcare, increasing the amount of co-payments, of private payments, so that we cut the bottom of the pyramid away and we can focus on catastrophic care. Also, changing the structure, like focusing on high-level healthcare centers that are packed with technology and highly qualified staff, and then have the long-term care and rehabilitation to sort of allow for patient flow. Probably as a part of the cuts in the bottom of the pyramid, we can speak about telemedicine as well, although telemedicine does not have such a lot of opportunities here because the country is really small. So it's not like Australia. And without increasing private money in the system, like burdening patients with co-payments, we will get to bankruptcy, because the other solution is just to increase the insurance fees, which is politically completely unacceptable.
Here in the U.S., there's also a lot of research and discussion about how to reform our mostly private healthcare system and keep and expand Medicare and Medicaid. It's the closest we have to universal coverage, of course, Medicare and Medicaid. In episode 15, Emory University's Dr. Stephen D. Culler zeroed in on doctors' paychecks.
What we don't do in this country is ask why healthcare is so expensive. And then you look and see that a doctor in the United States makes almost twice as much as a doctor in Europe. And then you look and say, 65 to 75% of every dollar in healthcare goes to somebody's income, whether it's a nurse, a doctor, a lab worker. And so the question I always ask is that, do we fundamentally need to restructure the pay in this industry? Has it got completely out of hand?
The UK's National Health Service may be the oldest and the best known of all the universal health coverage systems. It's the model for many other countries' health systems, but it's faltering. And the crisis is so bad, many fear that the NHS, which celebrated its 75th anniversary this summer, may not make it to 76. In episode 11, I talked with David Hunter. He's Emeritus Professor of Health Policy and Management at Newcastle University. I was in Prague, and he was in Northern England.
I think if they were to say what made them proud to be British, the NHS would come, if not top of the list, very close to top of the list. So despite the problems that have been inflicted upon it by what I will argue are poor political choices, people have great faith in the NHS. They're very loyal to it. They believe in it. They want it to survive. They want it to continue to be free at the point of use. They do not want a different healthcare system. They want the present one to function more effectively.
My interview with Dr. Lisa Lane in episode 7 touched on the many hats she's worn in her work life: Foreign Service Officer, patient advocate at a New Jersey hospital, and now an adjunct professor at Fairleigh Dickinson University in New Jersey. She has a doctorate in medical humanities and additional certificates in bioethics and medical humanities. And toward the end of our conversation, I asked her if people simply lived in a healthier manner with less medical care required, well, wouldn't that mean that people in some areas of our country who really can't access much medical care now, here and in the rest of the world, would simply need less of it? Well, Dr. Lane said for that to happen, we would have to raise the economic profile of many, many people.
What you're saying, all of that, living better, eating better, exercising more, that is still in the realm of the elite, of those people that have money. When you're poor and when you're hungry, you don't have time for that. When you are anywhere in the world, when you're trying to scrape making a living, all of what you've just mentioned is a luxury. It's a luxury. We as Americans, we pretty much see it as, it's what we need for a healthy lifestyle. But many people can't afford a healthy lifestyle. I mean, if you don't have quality food in a poor area, and the vegetables and the fruits and all, well, one, you're not used to eating them, so you're not going to. And two, you can't afford them. And three, you can't get to them.
I talked to Gina Majorek this summer, and the conversation became episode 13. Gina's a friend, an American from New Jersey. She currently lives in Germany with her Czech husband. But over the past 24 years, she has also lived in the Czech Republic, France, and of course the U.S., where she grew up. Gina has a chronic illness, so she's very good at comparing healthcare systems, as you might imagine. They're all state-run, except, of course, ours here in the United States. We talked on Zoom, me in Prague and Gina in her small German city. I asked her what she thought might improve healthcare for patients in any country.
I believe that doctors should be trained for not only this medical medicine. I believe that they should be trained on how to be a human, actually, and work with patients. And also, and that's a huge generalization. As I said, I've had really good doctors in all three countries. That's not, I don't want to get any ruffled feathers or anyone's feathers ruffled. But I also believe that they should study more homeopathic methods.
You probably know the name Dr. Richard Saltman. He's professor emeritus at the Rollins School of Public Health at Emory University in Atlanta. And he provides a lot of research assistance for this podcast, so you've probably seen his name and heard it a lot. He also happens to be my brother, which has certainly been of enormous help to me, and it's one of the major reasons my podcast made it through a year and a half. Richard has done a lot of research comparing major healthcare systems, and in episode 5, he focused on medical outcomes.
I am not claiming that the U.S. healthcare system is perfect. I would never argue that there aren't people in a country of 330 million who have difficulty accessing care. No question, that exists. But when you start to talk about outcomes, if you look at clinical outcomes, the clinical outcomes in the United States are very good.
There is, however, one huge problem in the U.S. healthcare system, and almost everybody here complains about it and worries about it constantly: the high cost of prescription drugs. That cost is negotiated lower in all other countries, but not in the U.S. In episode 16, Alan Weil, editor-in-chief of Health Affairs, said start with the idea of drugs as a market commodity.
One of the things that the industry has been very effective at in the United States is convincing a large number of policymakers in particular that the drug innovation that we have, which of course we all benefit from when drugs are affordable, is only happening because of the large profits that can be made on successful drugs to offset the investment in drugs that don't make it. And there's a lot of reason to be skeptical about the details of that argument.
In episode 10, we highlighted a huge problem facing many families: what to do when mom or dad can no longer live on their own, and the emotionally difficult decision to find a long-term care home. Rich walked us through his family's journey in North Carolina with their 92-year-old mom. I included some U.S. research links in the show notes.
We probably showed it to her, took her over there 4 times in a 2 or 3 week period. So she had a chance to process all of that. At times she said, I think I want to go back up to New Jersey. And we did have our sister, who still lives there, look at some of the options up there, just so we could tell mom, yeah, we looked at it, but they're even more expensive in New Jersey than in North Carolina. And let's remember, we want to be able to visit you regularly. There are more family members down in North Carolina. So we kept kind of repeating that message to her, and she finally accepted the fact that she needed to move. She seemed a little bit worried initially, and that's why we all thought, okay, this might take 2 months before she gets acclimated, but thankfully she got into it right away. So I mean, it's not perfect, but she's happy. She has things to do. They're looking after her. This place is even a little bit closer than the other place, the independent living facility, so I think we're getting over there a little bit more regularly. So it's really worked out well in the end.
We have had so many problems adjusting to the return to regular life after the COVID-19 restrictions were lifted that I spent 2 episodes, 8 and 9, talking to Dr. Radek Piekny. He's a friend who's a clinical psychologist and psychotherapist in Prague, and it kind of felt like our own personal therapy session at times. In episode 9, Radek agreed with my totally non-professional observation that many of us could use some mental health counseling, perhaps starting with the new apps that COVID helped create.
I think that it's very important to talk about mental health. That it's okay. I think that the younger generations are more open and more educated. And that's great that to know that, okay, if you have problems, that you are not a bad person, you are not weak, that's just normal. Everybody has strengths and weaknesses, and that's okay. That's how it is. And it's absolutely normal. It's not about perfectionist. It's not about to be perfect.
So there you are. A quick look back at just some of what this podcast covered in its first year and a half. Now, there's a lot more planned now for 2024, including revisiting some of the healthcare issues which just don't seem to go away. In episode 18, we'll move over to Sweden and how it's trying to modify one of the first government-run universal healthcare systems to absorb 21st century demographic changes and also to pay for fast-moving medical breakthroughs. I schedule 1 new podcast a month, so look for this next episode in February. The drop day is usually the 3rd Tuesday of the month. Updates on my show notes podcast page. I'd really appreciate it if you would subscribe and, of course, share. We're on Apple, Google, Spotify, TuneIn, iHeart, Podchaser, and my host platform, the Podbeam app. The video version's on YouTube. Show notes and links on my website, www.stephanieshelton.com/conversations. If you like the podcast, it would help a lot if you'd leave a review or give us a rating wherever you listen or watch. I'm Stephanie Shelton, and until I see you again, please take care of yourself and all those you love. Conversations on Health, How We Get There is produced and edited by Frank Herold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.